18th virtual shadowing session. My name is Taylor, and tonight we're talking about a spiritual journey in medicine with Dr. Christo Phillip. Just as a reminder, next week we're going to have a session on humanity and medicine with Dr. Fowler, followed by a specialty spotlight in anesthesiology, as well as after that we're going to have one on psychiatry too. So join us on Zoom at 7 p.m. Standard Central Time on Tuesday nights. As always, we have our working group consisting of Reagan, Shayon, myself, Alana, Rachel, Ani, Miriam, and Rohit, as well as Dr. Fowler and Dr. Marchetti. And then I also wanted to remind everyone that we're going to have a Q&A session at the middle and end of tonight's presentation. So be sure to put all of your questions in the chat as we go along, and hold all your questions about the assessment until the very end, because we.
So please hold your questions
Yes,
until the very
please,
end.
yeah, hold your quiz questions.
All right.
And other than that, please, I just wanted to remind everyone to be respectful and to keep their videos off, because we want to remain professional tonight. And that's it. Dr. Fowler, if you want to take it away.
I want to welcome everybody from all over the world who's joined us. We crossed 24,000 of you that have signed up for the website, virtualshadowing.com, in the last day, representing over 730 universities worldwide. We really didn't know when we started this that we were tapping into a real need, so that you, the future of medicine, pre-medicine, pre-PA, and other parts of the career in medicine, in the service to others, would be looking so much for having shadowing time. We are awfully excited tonight to bring Christo Phillip, Dr. Christo Phillip, to you. I've known Christo now for over 10 years, and he is one of the most amazing physicians I'd ever known. I had the pleasure of being a faculty member while he was a resident at the Parkland UT Southwestern residency. And without any doubt, as you're going to see in this presentation tonight, Christo is one of the most intelligent, intellectually driven individuals that I've ever known in my life, and that I've known a lot of people. And it was an absolute pleasure in the old Parkland working with Christo, because we were just absolutely packed, and his dependability, his grace, his love for all people was so evident during the time that I worked with him. Christo has traveled the world since then, and he has made a marvelous impact on the poor and the people who need care. And tonight he's going to share some of that with us. One of the things that you'll see tonight is diseases that we simply do not see in the United States hardly ever. And Christo, with his up close and personal connection as he's traveled abroad, will bring to us tonight something that you may never see again in your medical history as you pursue your own path in medicine. Christo Phillip, one of my favorite people. God bless you. So good to have you here. Could you join us and tell us about your spiritual journey in medicine?
Fowler, thanks so much for the introduction, and just for, especially for Taylor, for working with me on this session to really get this together. It really is a privilege and an honor to be able to talk to so many of you and share a little bit about my heart and about the journey that I have in medicine. You might kind of find it funny that where I'm sitting, you wonder, where exactly am I sitting? I'm actually sitting inside a closet, because as you can see from the picture, I have 10 children, and this is probably the quietest place inside the house. So that's why I'm here. I wanted to kind of just get into that and share a little bit of my story. So we'll begin by just a little introduction to me. I was actually born in India. I came to the US when I was 10, and I immigrated here with my family. And I really wanted to do medicine because I wanted to practically use my Christian faith. My faith from the time I was a young man, something very important to me in terms of the choices that I made. And I wanted some way in which I could marry that with my career and be able to combine both those things into what I did. And so actually my first experience kind of combining those two things was when I was about 17. This is actually some pictures of me when I was working at a mission hospital in southern India. And the man on the bottom was a gentleman that has leprosy, that I'm taking care of his wounds. And then probably one of the most vivid memories that I had was for this lady that I'm injecting up above. It's an elderly lady that was gored by a bull, and the doctor that was there that night called me in around midnight and said, "Hey, Krista, come up here. I need you to help me with this case." And that was the first time I learned to stitch. And so that from that on, I was hooked onto medicine and seeing how I could combine that with my faith. I went on to do my undergraduate degree in molecular and cell biology at Texas A&M University. So for any Aggies out there, a big jolly whoop to all of you. And after that, I completed my degree pretty quickly, and primarily because I wanted to get married. I had met Melissa, my wife, and she was actually the house mother at an orphanage in India where I'd worked. And my dad's one requirement was that you can only get married after you've got your college degree done, and you have to have a job. And so I said, Dad, well, I'll get that done quickly then. So I finished my undergrad in 3 years, and then I took on a job as a chemistry teacher. I taught actually in an inner city school in Dallas. And so I met my dad's two requirements. And so then right after I got that job, we got married. And I decided, since I had this extra year, I would go and use that to kind of do something else different before I started my career in medicine. So I taught high school chemistry. And that was just a wonderful year of learning and growing, especially in terms of understanding how the background that you come from significantly affect your outlook on life, and also the health problems that many of my patients would face in the future. After that year, I went on to do my training at the Mayo Clinic College of Medicine. And that's where I was then for 4 years to do my MD. And then one of the great things that Mayo has is they have an opportunity during your 4th year where Mayo will actually sponsor you to be able to go and work abroad and give you funding for that. And since I knew that I wanted to spend time abroad and work in a mission hospital setting, I went and worked at a hospital on the border of Myanmar and Bangladesh, which really confirmed my work or my calling to work in the developing world. After I finished at Mayo, I came to UT Southwestern, where I met Dr. Fowler at the emergency medicine residency here. And one of the things I was really thankful for was that they knew from the very beginning that the reason why I had gone into medicine was because I was interested in working at a mission hospital long term. And they encouraged that love for me, and that really made it possible for me to get extra time. And so during my 3rd year, I was able to cobble together almost 2 months of time where I was able to then go and work at a mission hospital in Bihar, which I ended up later joining, and then a second hospital on the foothills of the Kashmir area in northern India. In 2013, I had gone into medicine always thinking that our long-term career was going to be working at a mission hospital. And so in 2013, I moved my wife and our 3 kids to the poorest part of India in a state called Bihar, which has by far the lowest life expectancy rate. I think the average life expectancy is about age of 47. One of the highest infant mortality rates, about 1 in 5 children there die before the age of 5. And a lot of our friends and family thought we were just crazy. Why would you take your kids, especially your little ones, to this very remote part of the world? But we just felt like this was an outworking of the calling that God had put on our life, and that this is really where we wanted to serve. And that's why we had gone into medicine. And so we were glad to do that. While in India, I served as the director of the intensive care unit and the emergency medicine department at Duncan Hospital, and I did that for 3 years. This is our ICU. It's a 11-bedded ICU that took care of both medical and surgical patients, pediatric and adult, and OB patients. So kind of a mixture of all these things that required ICU level care. I would end up managing them in the ICU there. And then I was also blessed with a really good team. They call it the casualty department. That's essentially the same thing as our emergency department here in the US. And so this is my team of nurses and techs that work with me in the emergency department at Duncan Hospital. And I'll share a little bit about this a little bit more later, but then we were unexpectedly exiled from India in 2016, which then found us back in the US. And we have been trying to kind of figure out what to do. And during that figuring out process, we added on a couple more children, in fact, about 7 more kids. We started off initially saying, hey, we're willing to take maybe 2 or 3. We'd always thought we would adopt long-term. We had actually limited the number of kids that we would have biologically because we wanted to have the room to adopt in the future. And so when we found ourselves back in the US unexpectedly, we thought, well, now is as good as time as any to be able to consider adoption. So we started working through the foster care system and said to our adoption agency, hey, we can take maybe 3, maybe 4. And then a couple of days after our licensing was done, they called us and said, hey, how about 5? And we said, let me think about it. So we talked to all the kids and said, sure, we can go with 5. So we ended up getting 5. And then over the last couple of years, 2 more got added, which were the younger siblings of the 5 we'd adopted. So we now have 10 kids, which is how we have so many children as in the first picture. A couple of objectives that I want to share. I really want to make this a personal experience in terms of my experience in medicine, and it's really to share some stories of how my faith is intertwined with patients I've had the privilege of caring for, both in the US and around the world. I hope you'll be able to see some lessons I've learned from caring for patients that will be helpful to you as you start your career in medicine. And then finally, help you gain a global perspective on health and the large disparities found around the world. Hopefully some of the stories that I share will help you see just how privileged we are, especially in the US, in terms of what we have available compared to many other parts of the world. So just a little bit about the hospital that I worked at, and that'll give you some context as to where we were. We are in a place called Raxaul, Bihar. So this is India. This is the Bay of Bengal down here. This is the state we're in. It's called Bihar. And then where it says A, that's where the hospital is located. We're literally about 1 kilometer from the Nepali border. If you travel about 6 hours north of us, you'll get to Kathmandu, which is in the foothills of the Himalayan mountains. And then the next biggest city is about 6 hours south of us, which is Patna. That's the capital of Bihar. And so we're kind of juxtaposed between these 2 fairly large areas where we were often kind of the only place for people to get good medical care. A little bit of the history of the hospital. It was started in 1930 by a doctor named Dr. Cecil Duncan as a Christian mission hospital, reached out to patients in Nepal and northern Bihar. He actually was not allowed to enter into Nepal. So he said, well, if I can't go to Nepal, I'll build a hospital on the Indian side, and the Nepalis can come to me. And so historically, about half of our patients have been people from Nepal that cross the border daily into India, come get their healthcare, and then go back to Nepal. We serve as a secondary referral center for about 11 million patients. Just to give you some context of what that's like, I believe that DFW area has maybe 2 or 3 million people that live in the DFW area. And if you think about how many hospitals we have, there's probably well over 50 hospitals that serve that group of patients. Now take that and multiply that by about 4. That's the amount of patients that we would care for. And essentially all of those would come into this one center because we were kind of the only place, especially if you needed ICU level care and needed ventilation, kind of the only hospital in the region that could do that.
Christo, in the North Texas region, we have 37 hospitals with cath labs. How many did you have there?
We had 0, including our hospital. We just gave TPA. So just to give you some perspective, it's really the worst of the worst, the ones that really could not get help anywhere. They were the ones that would show up at our hospital. So really the nearest closest hospital with comparable services were 6 to 8 hours away, either in Patna, the capital where we were at, or in Kathmandu in Nepal. And so many times, if we couldn't take care of somebody, most of our patients could not afford to get to a bigger hospital. And many times, if we said no, it was essentially to go home and die because there was nothing else that people could get to in a reasonable amount of time that would help care for their family member. On a typical year at Duncan, we see about 120,000 outpatients, about 19,000 inpatients, and they did about 5,600 deliveries a year. And during the 3 years that I was there, we had an OB on staff about 6 months of that time. And the remainder of the other 3 years, all these 5,000 some odd deliveries were done primarily by residents and other doctors that were not trained as OB-GYNs just because it was so hard to recruit an OB to come work there. I thought I'd kind of begin just some interesting cases and just to kind of pique your interest. Sometimes, people ask me, hey, what is the fastest heart rate you've ever seen? And one of my nurses in the ICU at Duncan called me and they said, hey, Dr. Philip, there's a patient that has a heart rate of 300. And I said, that's impossible. I've never seen a heart rate of 300 before. And she said, no, it really says 300. That's what I said. Well, there must be an error on the monitor. There's no way somebody's heart rate can go 300. And so I sauntered on up to the ICU and looked, and there's a little baby who's about 2 days old. And this was the monitor. And indeed, as you can see, the heart rate is going 309 beats per minute. And the child, amazingly, was still alive. And the heart could just tolerate a heart rate that fast. And of course, I said, well, this clearly looks abnormal. Nobody's heart's supposed to beat at 300 beats per minute. And so I gave the baby some adenosine, and sure enough, converted to a normal rhythm. Still fast but for a baby, quite normal heart rate of 164. So that's definitely the fastest heart rate I've ever gotten to see. And then somebody asked me, what's the slowest heart rate you've ever seen? Well, one of my residents that I was training called me and said, Dr. Philip, I need you to come in because I've got a guy that's got a heart rate of 16. And I said, well, that's impossible. Nobody has a heart rate of 16 and is still alive. And he said, no, I felt the pulse. And sure enough, it was 16. That's what he said. So I said, well, let me come up there. So I look on the monitor, and sure enough, you can see his beats. And these are what I call his P waves. That's where the atrium is trying to beat. And there's his ventricular response. And his ventricular response is indeed 16. And I asked the man, well, how do you know something was wrong? He said, well, I'm fine when I lay down, but whenever I stand up, I just pass out. And I said, well, let me take your pulse. And sure enough, his pulse was going at 16, and I could very easily understand why he'd pass out since he had essentially no cardiac output because his heart rate was so slow. He actually had a third-degree heart block, and we put him on a medicine called isoproterenol, and that's him after isoproterenol running at 62. Of course, we don't have a way to get a cath lab, so no pacemaker available. So my job was to teach this family how to run an isoproterenol drip for the next 6 hours while they took him on an ambulance to a bigger hospital that could do it. And of course, this is an uneducated family that never run an isoproterenol drip before. So they asked for instructions, and I told them, well, if he says that he feels really jittery, that means your rate is too fast. You need to slow it down. And if he starts passing out, that means it's too slow and you need to go up on the drip. And somehow they follow those instructions. The man made it alive to this other hospital about 8 hours away and did get a pacemaker put in and went on to do fine once his heart rhythm was fixed. So I wanted to kind of break this talk up into maybe 9 lessons that I've kind of learned over the years that hopefully will be encouraging to you, and just some things that I've learned. And one of the lessons that I've learned over the years is that access to good healthcare is a privilege available to a minority of people, meaning there are very few people in the world that have access to good healthcare. And I wanted to share a couple of cases that I think will be helpful to help understand kind of the disparity in healthcare available in the world. So this is a 7-day-old baby that came to our hospital with difficulty feeding and what the parents described as seizures. So I want you to take a look at the child. As soon as we touch the baby, you can see the baby is going into these spasms and kind of calms down. And anytime you stimulate the baby, the child will keep doing this. So if we touch his foot, you can see again, these spasms would come on, making it quite difficult for the child to breathe. And this is a pathognomonic finding in someone that has infant tetanus. Infant tetanus is hardly ever heard of here in the US, but in the developing world, it's actually quite common. And in our area, the particular problem was that most of the babies that were delivered at home, common practice was in order to get the umbilical cord to dry up, they would take cow dung and they would apply that to the umbilical cord, which of course has lots of pathogens, one of them being tetanus. And this child, unfortunately, has infant tetanus, which has unfortunately has 100% mortality. This is another man that I took care of. There's a 49-year-old man that came with involuntary tightening of his muscles for a day. And the way that we distinguish these from seizures, that people that have seizures, when they have them, they're quite confused afterwards, but people with tetanus don't have that problem. So this man was brought in because they said he keeps having seizures, but he was talking to us in between these seizures. And I had just put him on a ventilator because he was having a hard time breathing. And to take a look at this video. So he's actually completely awake, and it's just these recurrent spasms that would happen because of stimulation. And the clue in tetanus always is that these spasms always happen with a normal mental status, as opposed to seizures, where the mental status is almost always altered. Tetanus is hard to make the diagnosis with a laboratory test. There is no great laboratory test. The simple bedtime test that we would always do in our patients, we got probably about 2 to 3 tetanus patients a month, and it's something called a spatula test. And literally all we do is you just take a tongue depressor, put it inside somebody's mouth, and try to get them to gag. And normally when everyone tries to gag, what happens is that as you gag, people will push the tongue depressor out of their mouth. But in tetanus, because the muscles reflexively spasm, they don't have the ability to do that. So instead of gagging and pushing it out of the mouth, what will happen is that as you put the tongue depressor in, they will bite down on the tongue depressor and they won't let go. And as soon as we saw that with the right history, we would say, oh yeah, this person for sure has tetanus. So what is tetanus? Tetanus is caused by an organism called Clostridium tetani. It's a neurotoxin that it produces called Tetanus spasmin. And the muscle spasms occur throughout the body. That's where you hear the term lockjaw or trismus. That's what causes them to bite down and make it so that they can't let go. And the hallmark is always that they have a clear mental status, because the issue is not with their brain. The issue is with the neuromuscular junction not being able to relax properly. It has a very short incubation period, about a week, very high mortality rate, probably 30 to 40% of patients that even with good treatment will end up dying from tetanus. And the hallmark for tetanus management really is managing their airway. That means that we almost always end up doing a tracheostomy where we cut a hole, because oftentimes what will kill them is that they get spasms of the vocal cords. And so essentially their vocal cords spasm shut and then they suffocate to death. And so the idea of the tracheostomy is to make a hole underneath the vocal cord so that they can breathe through it. And really, it's aggressive sedation, meaning you put them on very high doses of sedatives and you try to keep them alive until the toxin gets out of the system, which typically takes about 4 to 6 weeks. And this is where I finally learned how to use sedatives. And just to give you some idea, I know that many of you have not yet learned dosing of drugs. Diazepam is a medicine we often use for people when they need to be sedated. 5 or 10 milligrams of diazepam would put me or Dr. Fowler to sleep without any trouble at all. But when tetanus, because the spasms are so intense, I would often give between 400 and 800 milligrams of diazepam per day just to manage their spasms, because they are so difficult because of the current episodes of these spasms they get throughout the day. And unfortunately, tetanus is primarily still a disease seen in resource-limited settings because of lack of access to vaccines. You know, all of us are vaccinated against tetanus, but that isn't available in many parts of the world, and especially in a agrarian society like we're working at. People get a small injury on their foot or their hand, they don't realize it, and within a week, they start having these spasms, and by then it's too late because the toxin is already in their body.
Christo, you know, when you give a host of Ativan, you can get an acidosis from the propylene glycol that it's suspended in.
Mm-hmm.
Does Valium have some solvent that also causes its own problems with these massive doses?
Yes. And so what we actually have done is that to make it one cheaper and then to avoid the second problem is that we actually put an NG tube down and we give oral diazepam actually through the NG tube. And you can get large amounts of oral diazepam. And because the gut is there, many of the complications you face in terms of the solvent that goes along with it, you don't have to face because the gut absorbs it really well. Because in fact, the gut works just fine. It's just that the rest of their body is spasming. And so what we found is that diazepam in IV is probably 10 times the cost, but diazepam orally is maybe 5 or 10 cents per dose. So much cheaper, especially when you have to go to very large amounts.
So Christo, you didn't see tetanus at Parkland. How did you recognize it when you first got there?
So I had some good colleagues, and there's certain common diseases that everyone there knew about. And the first time I saw tetanus, I really thought they had a seizure. And they said, no, look, they're completely awake in between. It can't be a seizure. And then you had the history, and sure enough, they had an injury, something on their foot or their hand. And in fact, it's interesting, actually, Duncan Hospital has an interesting place in history. They actually published one of the first studies looking at aggressive treatment of tetanus back in the late 70s in the journal called Lancet, which is a very important medical journal published from Britain. And it was looking at the use of immunoglobulin specifically being injected into the CNS So they would actually, the protocol at Duncan early on was that they would actually inject this tetanus immunoglobulin into the CNS, which they found actually would decrease the rate at which they had complications. So if you look at that and you look for Duncan, because even now, even though we see maybe 3 or 4 cases a month, it used to be that they actually had a tetanus ward at the hospital because there were so many cases. And at any given time, there were between 20 and 25 patients that had tetanus at a time at the hospital because it was just so common. So it's still common, but not near as much as 20 or 25 patients per at any given time at the hospital. So we'll go on to the next case. This is a 4-year-old male that actually was brought to me in the emergency department with difficulty feeding and trouble keeping his head up. And actually, this is one of our pediatricians there that's doing the exam. And I want you to just look at this boy and how he reacts, and then we'll give you a clue as to what the diagnosis is. So this child is completely awake, and we're asking him to sit up. And as you can see, he is just flaccid. I mean, he has no control over his trunk. He can't keep his head up. At this point, he's still breathing, but all the other muscles are extremely weak, very difficult for him to move. And the history was that it began actually as weakness that initially began in his head, around his neck muscles, and then progressed downward to his hands and then to his feet. And they brought him in because he was unable to eat or drink. And once you learn neurology, you'll learn that there's only a few types of illnesses causes a descending paralysis, and this is one of them. And the clue again is that he's got a clear mental status, but he's got this descending paralysis that occurred fairly quickly. And we asked them a little bit more, and they said about 3 days ago there was a big celebration of the family. There was a marriage. There was a lot of food that was cooked outdoors, and this child had eaten some of it. And thankfully or not thankfully, only he was the one affected. Nobody else had gotten sick, but this child had gotten worse and worse, which is why he ended up coming in. And this child has a condition called botulism. Botulism is a fatal toxin caused by the bacterium Clostridium botulinum. And what it begins with is weakness, trouble seeing, trouble speaking, followed by then arm and chest muscle and leg weakness. So that's what we call a descending paralysis. So initially trouble with their mouth and with their vision, followed then by arm and chest and leg weakness. Almost usually no history of fever. And the classic triad of bulbar palsy, that means essentially things that happen within the face and head, descending paralysis, lack of fever, and a clear sensorium makes the diagnosis of botulism. Foodborne botulism usually occurs a few days after eating improperly cooked food. You can also get it from wounds. You can give what's called botulinum antitoxin. It's not very readily available. For this particular baby, we had called to see the nearest place that would have it. And the nearest place was about 3 days away that would be able to get the antitoxin to us. And really, it's long-term supportive care with ventilation. You put them on a ventilator, and oftentimes they're on the ventilator for 30 to 60 days, waiting for this toxin to clear, just because this toxin essentially impairs their ability for their muscles to conduct, get the nerve signals, and then respond. So this particular child, we knew that we wouldn't be able to take care of him because he was going to be on a ventilator for quite a bit of time. So I intubated the baby, and again, lack of ambulances. So we had a Jeep that would then take the baby from there to a bigger hospital that potentially could provide care for him. And then I had to teach the family how to ventilate the baby. So essentially we give them a tube and then a bag, and you tell the family, make sure you bag the baby and push on this bag every 5 or 10 seconds to keep the baby breathing until they got to the other hospital. About 4 hours into their journey, the tube came out, and there were no other qualified medical personnel on the Jeep. The child unfortunately passed away because he just couldn't breathe and died from the toxin.
We actually had 7 cases of botulism show up the year I got to Parkland in 01. And as usual, it was a picnic and people served food that was, you know how that works. And of course, we were able to get the antitoxin at Parkland, but I haven't seen it in 18 years.
Yeah, definitely not a common diagnosis at all. This is another woman that I took care of. It was an 18-year-old woman that came in with a severe sore throat, and one of my residents actually seen the patient first and said, she's got a very muffled voice, and something just doesn't matter. She seems much more than just a regular sore throat. So I went and took a look at her, and you could already see what her neck looked like. And you'll learn later what the name of this condition is. But you can see her neck is quite swollen. And I immediately knew that her airway was getting very close to closing completely. So I knew very quickly we had to intubate and put her on a ventilator. So this is me going in now to intubate her, and you can see the back of the tonsil. There's this kind of a grayish membrane that is present on the back. And when I touch it with my blade, it just bleeds profusely. And when you see this and this neck, which actually is called the bull neck, this is classic for a condition called diphtheria, another condition that is vaccine preventable. So diphtheria is a infection caused by Corynebacterium diphtheria. And the classic here is usually fever, sore throat, and adherent pseudomembrane. That's that white kind of grayish membrane on the back of the tonsils. The problem is the pseudomembrane and the swelling can obstruct the airway, so it actually blocks the vocal cords, which makes it difficult for them to breathe. And diphtheria toxin not only causes problems with the airway, but it can also spread into the blood and cause problems with heart as far as conduction blocks and kidney problems. You treat with actually a fairly old antibiotic, just penicillin or erythromycin and diphtheria antitoxin. And the mortality rate for this one is about 50% of them will die even with treatment. But the big thing to remember here is that if people are appropriately vaccinated, this is an illness we never see. So this actually is that young woman's neck x-ray. And what you'll see is all this gas that's forming within the neck, which is what kind of causes the swelling of the neck. And I looked at the last time we saw this in the US. The last time it was described in the literature in the US is back in 1934. And in the last 20 years, there's been 2 cases in the entire US. So very unusual presentation, just because we have vaccines now that can prevent this illness. But this used to be a terrible illness that would cause lots of death from something that just sounds like a sore throat, but very quickly worsens. This is a 1-year-old female that came to me with lethargy and fast breathing after 20 episodes of diarrhea. The parents brought her to me and said that, over just a few hours, the child had gotten very ill. So when I went to see the baby, this is what I see, and I want to show you a video of what she looks like and how she's breathing. I want you to notice her eyes are sunken. She's very minimally conscious, and you can see her breathing. It's kind of this deep, what we call hyperpnic breathing. It's somebody that is severely acidotic breathes like that just because they're trying to get rid of the amount of acid in their blood. We checked the gas on her to see what her pH was. Normal pH for a human being is around 7.4. Hers was 6.9 because she was so acidotic. And whenever we hear this history of very severe diarrhea, very quickly progressing to the point where the child becomes unconscious, in our area, it almost always means cholera. So this is a child that has cholera. And we gave her a 60 ml per kilogram bolus, so that's a fairly large amount of fluid to be able to improve her mental status, and slowly she improved. And the medicine we usually give is doxycycline that helps decrease the amount of toxin that's produced by the bacteria. And we get these periodic outbreaks, and it can rapidly kill if adequate hydration not given. One of the saddest stories was of a couple of kids that I took care of that had cholera. They had actually, the father had brought 2 of his kids in because they were both having severe diarrhea. They were very dehydrated. We put them into the hospital, put them on IV fluids, and gave them what we call ORS, which is oral rehydrating salts. And while they're admitted, they both got better. What he didn't realize was that his wife was also sick at home. And by the time he went to go back home the next morning, he went to go check on her, and he found her actually, unfortunately, dead at home because over the course of the night, she had so much diarrhea that she ended up passing away while he was taking care of his children. And we would see, mainly because of the fact that the hygiene in an area where there's poor access to sanitation, especially toilets, is not very readily available. What would happen is that people would have a community area where they defecate out in the open. And of course, very easy for that to again contaminate the water supply, which is how we would usually know is that when one would get it, then usually we'd get a cluster of them because they would all be in the same area. And really, the problem with this particular bacteria is really lack of access to clean water.
Christo, back in the 70s, I worked at the CDC, and I worked alongside the Epidemiology Intelligence Service, and they were putting together the beds that people with cholera would lie in, and the center of the bed had a hole in it. You've probably seen these, so that the diarrhea could go down through the hole because it was so much diarrhea.
Right. That's exactly, the cholera beds, literally they put a bucket underneath, and the amount of fluid that comes out through them is just amazing. And this is really where I learned about fluid resuscitation. Many of the adult patients would go through 20 to 30 liters of fluid a day because of how much diarrhea they would have. And unfortunately, if you can't keep up, they get very quickly dehydrated. And again, going through that much fluid via an IV is extremely difficult. So what we found, again, is that as long as the gut is still working, you can put an NG tube down, and there's no way somebody can drink 30 liters of ORS. It's just impossible. So what you do is you put an NG tube down and you connect a liter at a time of oral rehydrating solution, and you just let it pour in. And essentially they get a liter an hour via the NG tube, and that helps to keep up with the amount of loss. So that's how we taught our residents to calculate how much fluid they had. Essentially, it was to measure the bucket that came out, and whatever came out was the amount of fluid you need to come back in to be able to help get them through their acute cholera episode. So sometimes some of these babies come in, they're very severely dehydrated. We have very difficult time finding IV access. One of the things you can do when you don't have access to other things is in the US, we use what's called an interosseous needle. Interosseous needles are sometimes hard to find, especially in a developing world setting, but a 16 gauge needle works just fine. And so that's what we would often teach our residents. So if you had really hard time with finding IV access, just get a 16 gauge needle and you can just corkscrew that into the tibia, and then that can be used as your IV access until they get enough fluids in, that way some of the other veins pop up. So an easy thing that could be done in a resource limited setting. This next case was a boy that I met a couple years ago that came in with abnormal behavior from home. The family was concerned because he just wasn't acting right. And so they got in, and I want you to look at his video, and it'll kind of give you a clue to his diagnosis. Turn on the fan. So I've asked the nurse to turn on the fan. And as soon as you turn the fan on, he just has a hard time breathing. And he says, stop, stop, stop. Okay. Then I'm going to give him a glass of water. And you can see how afraid he becomes as soon as we give him the water. Until I'd seen it and recognized it, very hard to know what exactly is wrong with this child, just was not acting right. But once you've seen it a couple times, very clear that this child has rabies. We asked the family a little bit more about the history. Unfortunately, this boy had been bitten by a dog about 8 months prior on his leg. And it had taken 8 months for that rabies virus to get into his system, slowly crawl up his peripheral nerve, get into his CNS. And once it finally gets into the CNS, that's when the abnormal behavior happens. And so this boy actually has dog rabies. And rabies is a Lissa virus that's transmitted to humans from animal bites. The virus enters the body and slowly travels up the peripheral nerve, about 1 to 2 millimeters a day, which means it takes often weeks to months for this to happen. And the reason why I took this particular child almost 8 months to finally develop clinical rabies was because he was bitten in his leg. And that nerve to get up to the spinal cord is fairly long. And so if it goes about 1 millimeter a day, it takes quite a bit of time for that virus to slowly come back up into the CNS. But once it gets to the CNS, it rapidly causes an encephalitis. And usually from the onset of symptoms, 100% of patients will die within a week. I'm sure you've heard of some people that have survived rabies. But unfortunately, those have almost always been bat rabies, which actually is a different type of Lissa virus than the one we have from dog rabies. There's still actually never been any survivors of somebody that has had dog rabies. And we see two forms of rabies. One is called a furious form, which is what this particular child has. It's about 80% of the time where they become increasingly agitated, delirious, and the classic signs are usually hydrophobia and aerophobia. So you show them water, they become very scared. It actually is a spasm that happens within the vocal cords, which makes it difficult for them to breathe when they see water. Or if you take a fan or you take a piece of paper and you wave it in front of them, that flow of air makes them have that spasm, and that's how you make the diagnosis. About 20% of them will actually develop what's called a dumb form, where they actually become paralyzed. There are a couple of cases at our hospital where we thought somebody had Guillain-Barré because they came in very weak, put them on the ventilator, and they just weren't getting better, not responding the way you would expect. And then when we finally asked the history, there was a history of a dog bite at some point prior, and that actually is the dumb form, where they actually come in with paralysis. Unfortunately, with dog rabies, there's very little you can do. It really is palliative care. And the sad thing, especially at our hospital, was how so many patients that would come in with rabies, and we saw a couple cases a year. As soon as you tell the family that they have rabies, of course, everyone is fearful to begin with. And what would happen to most of our patients that were diagnosed with rabies is that they would take the person that was affected, they would take them home, lock them in a room, provide some food inside there, and essentially leave them locked up until they passed away. Because what would happen is that as the infection set in and the encephalitis worsened, they became so violent and so difficult to manage that it was dangerous for anyone else to be around them. And it was just a very terrifying way to die. You're alone by yourself, you don't know what's going on. And anyone that comes around you, you're so agitated, you're violent. And we just thought for this particular boy, that would be just a terrible way for him to die. And so we started implementing a palliative care program for people that came with rabies. And this actually was a protocol developed out of Vietnam. They have quite a few cases of rabies there as well. And what we do is you put an IV in and you give them IV Haldol and Ativan and help to manage their symptoms. And the goal really for us was to give this boy a way to be able to die with dignity and allow for his family to be with him, because most patients will die, but will have no one around them as they pass away. The family was quite apprehensive, but we kind of showed them what would happen and said, at least we can offer him a dignified death. And so they decided to keep the boy in the hospital. We put them on Haldol and Ativan, and we just had one nurse assigned to that patient every day, so it limit the amount of exposure. And we just made sure that that nurse was properly vaccinated against rabies. I had already knew that I'd probably be taking care of rabies patients, so I'd already had my 4 shots beforehand. And so I would go in once a day and check on the child to make sure that his agitation was being under control. And he stayed with us for the next 3 days while his symptoms slowly worsened, and then ended up passing away. But the thing that was really meaningful to us was his mom was there to be at his bedside until he passed away, which otherwise would have been completely impossible. And she got to hold his hand as he ended up dying from this illness because of the fact that we were able to control his symptoms.
Christo, can rabies be transmitted from human to human? I don't know.
Yeah, it is carried within the saliva. So if a person that is rabid bites someone, then just like a dog passes it on, it can pass on between humans. So that's the reason why we try to limit the amount of contact. So I just ended up getting my booster shot for rabies, but I took care of him, and just made sure the nurses that were taking care of them were properly vaccinated, and try to make sure that you limit the amount of, especially exposure to the oral fluids that come in, because as they get worse, they often will start foaming at the mouth, and that will then allow for them to pass the virus on.
So if a caregiver got sprayed in the face by saliva, that would be very close to the brain, and it could be a quicker onset.
Right. And sometimes, we've had a couple of cases where people were bit by like a rabid a coyote, but one that was bitten in the face. And then in those cases, you have maybe a week or 2 before encephalitis will set in. So again, as soon as we make that diagnosis, it's to make sure they get the appropriate vaccination. I mean, as long as they get treatment for it, and they get rabies immunoglobulin injected around the site where they got bit, and then the rabies vaccine, it's a completely preventable illness. But the problem was this particular child was from a very poor family, so when they got bit, they never sought any kind of care, and thus no vaccination was given. And then unfortunately, by the time rabies presents clinically, by that point, it's too late.
Did you have access to the vaccines and the immunoglobulin as compared to other things?
Yes, we did have access to both. Yeah, we did have access to both, thankfully, because it was a fairly common thing. It's, I believe, both the vaccine and the immunoglobulin is produced indigenously in India, so it's relatively inexpensive compared to some of the other things that are hard to find. This is a 2-year-old male that came in with abdominal distension and respiratory distress. This was a child. They had taken this baby to several different hospitals before they finally came to us. And I want you to notice 2 things. One is the very protuberant abdomen that's there, the coarse features of the child's face, and the protruding tongue, kind of a very thickened tongue. And the mother's history she gave to us, even though the child is 2 years old, the child is unable to speak and still cannot sit up. Of course, that's when she knew something was wrong, because her child was not developing like other children her age or his age. And then if you look at the skin, you'll see it's a very kind of coarse, dry skin, which gives you another clue to what maybe the underlying diagnosis is. And then finally, I want you to listen to the baby's cry. The tongue here now. So even though it's a baby, it's a very hoarse cry, which would be unusual for someone this age to have a voice that sounded like that. We did one more test, which kind of cinched the diagnosis for us. I'm going to check the reflexes on this child to see how they respond. So I'm going to check his brachioradialis tendon. And if you watch his hand, it's the way that his reflexes come back. And it's called a delayed D10 reflex. It's that it has a quick upstroke and then a very slow downstroke. And whenever you see that, it's called Voltman's sign. And with the right clinical history, it's pathognomonic for someone that has severe hypothyroidism. And in this child, that's 2, this child has cretinism. Cretinism is a condition caused by severely depressed physical and mental growth due to congenital deficiency of thyroid hormones. You can get either mild to severe cognitive impairment, depending upon how long it is that's undiagnosed and how deficient they are of thyroid hormone. Classically, they have a thickened skin, a large tongue, a protruding abdomen. It's actually a very treatable condition if you deal with it early, but impossible to reverse in late condition. And really, this problem happens due to lack of access to appropriate screening. So in the US, all of our children that are born are screened for congenital hypothyroidism, but that's a luxury in most parts of the world. They don't have access to that. And if this child was recognized as being hypothyroid early on, you put them on thyroid hormone, which is very inexpensive. The child would have grown up and developed fine. But at 2 years, when all the damage has been done because of no thyroid hormone, very difficult now to reverse any of the condition that the child has. This is another case of a man that came to me that woke up from sleep with trouble speaking, swallowing, and severe abdominal pain. And I want you to look at his exam, and we'll give you a clue to the diagnosis. So I'm telling him to open up his eyes. As you can see, he can't really lift his eyelids. Right, he's got ptosis of both of his eyelids. And then I look at his legs, and you'll see these things called fasciculation. Do you see how the muscles are contracting? And whenever I see this in India, especially during the monsoon season, it's almost inevitably that this patient has been bit, likely from a neurotoxic snake. Within that area, it's either a crate or a cobra. And this particular man was probably bit by a crate. It's a snake called Bungarus ceruleus. It took me a while to realize exactly what this envenomation looks like. Many times they present initially with severe abdominal pain, almost like a surgical abdomen, severe vomiting, and they don't have any history of a bite. And this particular man, again, he lives in a hut, sleeps on the floor with the grain sacks around him. And of course, snakes will hunt through that area because they're looking for mice. And likely at night, crates are usually not very aggressive. Likely at night, he rolled over probably onto a snake and bit him, but crates are pretty small, and many times they don't even leave a mark, so it's very hard to find exactly where they got bit. But the clue to us always was in the right season. Usually it's when it was raining outside. The snakes will leave the fields and try to find a shelter inside a home because it's dry there. When they came in with severe abdominal pain in that right season, I'd always worry, is this a crate bite that's just presenting itself early? And whenever we saw that, we just put them very close to a nursing station, just keep examining them and see if they start developing muscle weakness, specifically ptosis or difficulty with their speech. That would let us know this person probably needed to be intubated. If you recognize a person has this envenomation, you give them antivenom and you do early intubation. We would also see cobra bites, which cause more local tissue injury, although they do still have the problems with neurotoxic effects on the diaphragm as far as making it difficulty to breathe. But in crates, the good thing is that as long as you put them on a ventilator and they get to the ventilator on time, within about 2 to 3 days, they'll almost all get off the ventilator once the toxin gets out of their system. But again, something that is very treatable if you have the right environment, to have a proper environment to sleep in, then you don't get access to these snakes. But when you're on the floor and surrounded by these animals that you get onto them accidentally, then you get bit and unfortunately get the complications from it.
Christo, the toxicology group had a talk from the snake keeper at the local zoo here recently, and he said that the antitoxins were getting harder to get. Apparently, it was a problem with production or something. Were you able to get antitoxins?
Yeah, so we definitely had antitoxin to the neurotoxic snakes. So in India, they produce it against kraits, cobras, and a couple of the pit vipers, and we could give that to them. But we often had a question as to whether it was worthwhile giving that versus just intubating them, especially if we knew this was just a neurotoxin. The antivenom itself, just like in the US, it's very expensive. And sometimes you go through 6-10 vials of antivenom. And especially if we knew it was just a neurotoxic envenomation, many times we just put them on a ventilator, avoid the antitoxin. And it was cheaper for us just to ventilate them for a day or two, as opposed to giving them the antitoxin, which many times would still end up being on a ventilator. So we would kind of talk to the family about what we think we could manage. And thankfully, the neurotoxin, once it gets out of the system, they're completely back to normal. So you just need to support them through their paralysis where the diaphragm doesn't work. And as long as you can do that, almost universally, they all do well. The only times we've seen some trouble is with cobras. When they have bites on the arm or leg, many times they get severe necrosis from that and end up getting lots of tissue loss. But kraits often didn't have a problem. So that was the first lesson, was to just, access to care is really a limited resource and one that very few people have access to around the world. The next lesson that I want to kind of share with you is that with God's help, you can do things that you thought impossible. I think, in being in Bihar, it's really pushed me to my limits in terms of what I have done and what I thought I could do. And there are many things that I've never done before, especially when I was in the US, but I was forced to just because there was no other person to be able to do the work that needed to be done. And many times I've gone in and it was just with a prayer that said, God, please help me get through this because I don't know what to do. But if I don't go in, there's no other person that's anywhere nearby that can help them. And so I wanted to share this case. This was a 24-year-old woman that had just delivered. Actually, she had lost the baby because she had labored at home. One of the common complications we saw at the hospital was ruptured uteruses. What would happen is that, especially if they've had a prior C-section, but even if they didn't, if they labored at home for too long, what happens eventually is that as the uterus kind of weakens out, they can rupture open and the baby actually goes into the abdominal cavity. And this particular woman had come in. She had ruptured her uterus and the baby was actually free floating in the abdomen, lost a large amount of blood. And when she got here, she had already at that point, was pretty hypotensive. Blood pressure was in the 50s and 60s, very pale. I think they'd already given her at this point, maybe 3 or 4 units of blood just to get her to the operating room to see if we could stop the bleeding. She actually arrested right after the operation, and they found almost 2 liters of blood inside her abdomen. And got her back after the operation. They actually ended up taking the entire uterus out, clamp off the vessels that were bleeding, and then brought her up to the ICU where I was managing her. But then over the course of the evening, she continued to worsen. I was looking at her blood pressure. Initially, it was in the 110, 120 range, and over the course of the evening, started dropping into the 70s and 60s. I did an ultrasound of the abdomen and saw the abdomen was again filling up with blood. So it was clear that the patient needed to go back to the operating room, but with a very tenuous blood pressure. So we didn't have an anesthesiologist at the hospital, and all the cases were managed by a CRNA. And so the CRNA calls me about 1 a.m. and says, Dr. Philip, I need you to come in and do this anesthesia case with me because I don't know if I can manage somebody that's this hypotensive through anesthesia and get them through her surgery. And I remember just waking up in my bed and just thinking, I have never given anesthesia before, definitely not to someone that is this hypotensive, getting them through an operation. I have no idea how to do this, but this person is asking for help, and they would feel so much better if I'm in there to be able to help assist them. And so I remember just, I talked to my wife, woke her up and told her, look, I'm gonna go in and try to help with this case, and I just need you to pray for me. And we prayed that somehow God would give me wisdom to know how to manage this case and get her through the surgery. And so the anesthesia agent that I had used before that had worked for, minor procedures was a medicine called ketamine, which is readily available. And so I decided I would do the entire case under ketamine. So we gave this medicine called ketamine, which actually has fairly good cardiovascular profile in terms of not dropping their blood pressure further. And then as we put her on ketamine, we also had her on a dopamine drip to keep her cardiac output up while they went to the operation. And once they went in, they found out that several of her uterine arteries were still continuing to bleed. And so they had to go back and resuture those. And you can see the black here is all the clots they removed from her abdomen. And somehow God helped us through that case and got her through this operation. She didn't remember any of it. And by the time we had finished the operation, her blood pressure stabilized. And the next day, she was able to go home or get out of the ICU once the bleeding had stabilized. Another lesson that I wanted to share is that patients really want physicians who can relate to them. What do I mean by that? It doesn't matter if you're the smartest doctor in the world. If your patient cannot relate with you, what little you can do for them won't stick, and they won't follow through on instructions you provide for them. And I wanted to share a case of someone that I took care of where I thought this was very true. That somebody else had already made the right diagnosis, but because they didn't take the time to talk with them and explain with them and kind of help them through this, what they conveyed to them went in through one ear, not the other. This was a young man. He's probably about 14 years old. His name is Pintu. He came in to our emergency department, and one of my residents called me and said, "Dr. Philip, I want you to come look at this because it's an unusual exam." And so you can see how he's holding his hands. He's got spasm of both of his hands. He can't open them up. And then I'm going to touch his facial nerve there. And when I tap it, you'll see that his muscles reflexively contract, which is a sign we call Schiff's sign. And it's consistent with somebody that has severe hypocalcemia, which would also go along with carpal spasms. So you can see, look at his x-rays and his fairly short stature. He actually had what they call, these are called butterfly vertebrae. It's a congenital anomaly. He actually has a whole host of anomalies in his spine that tells you there's something else going on. This is probably congenital. His calcium, when we checked it, was 0.6. It was extremely low, and the reason why he was having such bad spasms was because he was having what's called tetany, and that happens when your calcium goes really low. So based on that, and we checked what's called a phosphorus. His phosphorus was fairly high at 10. We made the diagnosis of probably congenital severe hypoparathyroidism, and we put him on IV calcium and a medicine called calcitriol, along with a second medicine called vitamin D, and then calcium tablets, and rapidly his symptoms improved. So I talked to him and his family a little bit more, and they said, is this a new diagnosis? And they said, no, we knew that something was wrong with this calcium. And in fact, he'd gone to several of the premier centers in India where somebody else also had made a diagnosis. And I said, well, why aren't you taking your medicine? Because no one took the time to explain what was wrong with me or what I would need to do. They thought you take the medicines for a couple of days or a couple of weeks, and then you'd get better and you could stop taking the medicines. And so this boy had been suffering because no one had just taken the time to be able to come and talk with them and sit with them and explain to them what is wrong, and the fact that this is a congenital condition that he would need to be on lifelong medications. And as long as he took his medicines, his spasms would stop. So this is him. He came back to me about a year later, and his father was so happy because he said, my son is a very smart boy, but the teachers kicked him out of school 4 or 5 years ago because the spasms were so bad, he couldn't stay in class because he would have these all throughout the day, and the teacher couldn't manage them. And so even though I know my son is smart, he's been at home for these last 4 or 5 years because nobody's able to manage them. But once we followed through on what you said, he hasn't had a seizure now in almost a year. And these seizures were all these episodes of tetany, and he was back in school. And it was so great for me to see him and to see the improvement that he made. And just that, we had in many ways been able to give his life back to him, just from some simple medicines that as long as he took daily, he'd be able to keep his symptoms under control. And really just took the time to really spend a few minutes to talk with them so he could relate to what was going on and explain to them what the underlying issue was, so that hopefully they could get the care they needed.
Christo, what is hypocalcemia? Well, this is good questions. Why does hypocalcemia cause spastic contractions like that?
Yeah, I think the physiology behind that is that it makes the muscles irritable. And so I think that's what causes the tetany and the spasms that go along with it. And if I had to go back to all my physiology, and I think it has to do with the amount of calcium that goes through the myoplasmic reticulum in terms of the ion exchange. And so I think that's what causes these muscles to contract. We see that same condition actually with severe hypomagnesemia can often follow with a similar type of presentation. So I'll stop right now for a few minutes and answer any questions before we go on.
All righty. So do you want me to start with the first question that we have? So the first question is, why is there such a high mortality rate among children under 5 in Bihar?
Probably the number one thing is lack of access to clean water and just basic nutrition. I mean, most of the kids in that area, the majority of their sustenance was primarily rice and dal, just 2 ingredients essentially. And so the access to anything else that has protein, that has other vegetables, other things that can help the nutrition, very, very limited. So we had lots of kids that would come in with kwashiorkor, where they would have these very protuberant abdomens just from lack of protein intake in their diet. So that's one. Second thing is probably living conditions. So probably 90% of my patients came from homes that were built out of mud-thatched buildings, which would mean that they're exposed to the elements. Number one, probably 70% of my patients didn't have access to running water or a toilet. And so if you just think about all the diseases that are spread because there's no proper sanitation, that's probably a huge part of why, especially kids, if you're an agrarian society where you're a farmer, you have 5, 7 kids, right? You have to go to work. Everybody has to go to work. Nobody's here. So many times the little kids are at home, right? And maybe an older kid is watching them. But if you think about this, surroundings around the hut, right? There's open feces, there's lack of clean water, and a little baby or a toddler doesn't know the difference, right? They get some of that into their system, they get sick. And so the number of kids would get from severe dehydration, diarrhea, or pneumonia, very common. The other thing is just lack of access to vaccines. Most of the routine vaccinations we get in the US, very few of my patients would ever have any of them. They might get 1 or 2 shots, but to have all the vaccines that are recommended for a child in the age of 5 is very unlikely, which then would contribute a lot to the mortality we saw in kids.
Certainly makes you appreciate all the things that we have here.
Yes.
This different countries in which you've practiced?
Say it again, sorry, you cut out.
Have your standards of care changed in the different countries in which you've practiced?
Yeah, so I think you have to be cognizant of what's available and cultural norms. So standards of care, for example, when there's a baby that came in with congenital heart disease, right? The standard of care in the US would be is that this congenital heart disease child would get to a pediatric cardiothoracic surgeon who would then do an operation, do a shunt, or further procedure to be able to stabilize the child. My standard of care in Bihar is that the vast majority of the patients, number one, getting to a cardiothoracic surgeon was next to impossible. There's no one in that area. Number two, even if they could, many times we have to consider what is the cost to the family to take care of a child that has congenital heart disease and then to be able to get them through a surgery and then the ongoing care required. It might be potentially feasible in terms of them putting the resources together. They might sell their home, their land to be able to do that. But then the question becomes, once a child has a surgery, how do they have money or funding to be able to keep caring for that baby? And how does the rest of the family survive? So these are not easy questions. There are lots of ethical dilemmas because yes, maybe I could get the funding together, or maybe the family could get the funding together to be able to take care of a child that's that ill. But then you have to think about the fact that that often means many other people in the family end up suffering or dying because they don't have access. They lose their home, they lose their land, the one way in which they had to be able to make any kind of money. These are not easy choices, and choices that we often don't have to make in the US are very important choices that we have to make and discuss with families because many of them, if they did what could be done would end up putting them all into a position where they wouldn't be able to support their families.
Wow. So sad, but I mean, like, that's really puts things into perspective.
Yeah.
Another good question is, have you ever faced conflict or experienced a clash between religion and science in your career as a physician?
Yeah, I think I'll maybe defer on that question for a little bit. I'll talk a lot more about that over the next few slides. So I'll talk a little bit about how I've kind of come to terms with those two things. So I'll maybe hold on. And if I didn't answer that question fully, I'll answer at the end.
Sounds good. Okay. How do you keep from getting discouraged by not being able to treat these preventable diseases when they get so far?
Very hard. Very hard when you see things that you just said, well, if you had just gotten that vaccine, and vaccines, even in India, vaccines are relatively inexpensive, but there's many misconceptions. There are communities where they've believed that vaccines would impair fertility in children. So as a community, many of them have chosen not to take vaccines. And a lot of it's just lack of education. And it can be really disheartening because you have the same conversations over and over again. And you just wonder, why is it? And then part of it is, is lack of education. And then part of it, I think you realize over time is building trust, right? People will do the right thing if they trust who's saying it, right? But if they don't have any relationship with you, very hard for them to trust what you're saying is actually true. And so that's really, I think, yes, I did work at the hospital, but the long-term work in the community was primarily done by our community team. And it was just them going in for years upon a time, building relationships with villagers, building relationships with the village headmen, right? So that they learned to trust us. And so that when something was wrong, they knew, hey, if I need to get some help, I can go to the hospital or somebody can give me advice. And part of it, I think, is that I think many patients were so despondent because so many had taken advantage of them, especially if they're poor, uneducated, they go to a doctor, they try to fleece them all their money that they have. And so they rightfully are very skeptical of things that you tell them to do because many people are not trustworthy. And so I think it requires just years of persistence and hard work to be able to gain people's trust so they learn to trust you and believe what you say is actually what's going to be good and helpful for them.
Okay. And then I think we'll cover one more question and we'll let you keep going.
Sure.
Do you find it hard managing your personal and professional life?
It's always difficult. I think it's definitely a little bit easier in the US where at least at the end of my shift, I come home and I don't get any more phone calls from the hospital. Very different in India where I lived on the campus of the hospital and I was on call pretty much 24 hours a day for 4 or 5 months at a time. And very hard when, even if it's your day off, when one of your residents calls you and says, look, I've got a patient that I'm trying to intubate, but I can't, and I need some help. Even if it's your day off and say, look, it's my evening with my family, I need to have time with my kids. It's very hard for me to say no when you know that somebody's going to die if I don't go in to help them. So these were hard conversations that we had as a family. And one of the things that we decided to do early on is that we kind of built in a system where every 3 months we took a break and we actually left the campus and went someplace else where nobody could reach us by phone or email. So I didn't feel the pressure of having to respond if somebody had a need. And I just told them beforehand, I said, when I come here, I'm already scheduled my next trip 3 months away, I'm leaving. And so my wife and the kids especially knew that even though dad was busy at the hospital and time was being taken away, at least they knew that 3 months from now, we had this time where I had exclusive attention with dad and we would have a week to be able to sit and talk. And so I think that's one part of it. The other thing is I've always made sure that my family was a huge part of what I did and the life that we lived together. It wasn't me going to the hospital and my wife and kids doing something different. We were all together as a team. And so, my kids rounded with me pretty much every day. One of the kids that was their kind of morning routine is that I would take one of them with me and I'd do ICU runs with them. So they kind of knew what I was doing. If I got called in, especially in the evenings when they were done with school and I needed to go see somebody in the hospital, one of the kids would come with me. So my kids have seen lots of intubations, lots of central lines being put in, gunshots coming in, and that was just part of their life growing up. And then the other thing we decided is that especially the staff that we had at the hospital, we invited quite a few of them into our home. And so I wanted our kids and my wife to feel like we were part of the same big picture. And so many of the interactions that I had with the residents there was primarily through the time that we spent with them in our home and spending time with our kids. And so I think that made them feel like they were part of it. And it wasn't just dad's doing this thing and then we're doing our life separately, that we're all in it together. And I think that made it a lot more bearable.
It's really cool to be able to like do it in that way, incorporate your family and like work life together.
Yeah.
Well, feel free to continue your presentation. We'll save a lot of the questions for the end.
Great. The next lesson I think I've learned is that job satisfaction has very little to do with money and everything to do with purpose. When I think about my work here in the US, I worked at a job in the US where I can make lots of money. When I lived in India, I made probably about 5% of what I made in the US. And many people would think, and this is a huge sacrifice. Why would you give up a comfortable life? In fact, many of my own family asked the same question. Why would you give up? You can have a good life here. Why would you give that up to be able to go and work in a place like this? But when I look at back my time overseas with our family, what I found that if what you're doing has purpose, that's what really brings you satisfaction. It's not really the money that you earn doing the job that you're doing. I want to share a story where I think this is really clear. This was a 19-year-old female that came to us. She was pregnant with her baby. She was about 23 weeks along in her pregnancy. And when she came to the hospital, she was extremely breathless, very difficult time breathing, and just difficult just catching a breath. And when she got there, her oxygen level, normal oxygen level is between 92 and 100%. Hers was about 50 to 60% when she got there because her lungs were having such a hard time getting any kind of oxygen in. And I immediately knew something was horribly wrong with her and knew that we needed to have, in order to have any chance, we had to end up putting her on a ventilator. So this is the first x-ray that I took of her after I intubated. So you can see the tube is in, and this is her lung right here, which is all white. It should be gray or black. And then you can see her heart. Her heart is quite large. And that kind of gave us a clue that was probably the issue with her. And you can see this is the PA window. That's the pulmonary artery window. Normally you should see a little notch here. That's all gone because it's all dilated. And this finding on the x-ray is classic for someone that has pulmonary edema. Essentially it's fluid in the lung. So we thought this issue is probably with her heart. And we did an echocardiogram, which confirmed the diagnosis. So this is her aortic valve here. This is her mitral valve. As you can see, her mitral valve barely opens. In fact, all the blood in her body is going through this little hole that's about 0.6 centimeters. So it's this tiny hole that all of her blood is going through. And the way the valve moves is classic for someone that has rheumatic heart disease. And she probably had strep throat as a child, and it ended up affecting her heart valves, and slowly over time the damage got worse and worse. And then she probably had lived with it and had compensated just fine until she finally became pregnant. And of course, when you're pregnant, the amount of blood that you have to circulate goes up by about 50%, and her heart just couldn't handle that amount of blood. And so what ended up happening was her lungs filled up with fluid because it couldn't pump forward anymore. So this is her on the ventilator as we try to figure out how to get fluid off of her lung. By this point, she was so sick that she had actually lost the baby. And our goal was to try to see if we somehow keep her alive until her heart could improve. And we put her on the ventilator for 3 days. And this is her x-ray, and we extubated her. You see the heart is still big, but the lungs have cleared up. And this is her and her husband with her mother-in-law that were there on the day she left the ICU. What really made this story meaningful for me was that it was a complicated diagnosis in terms of figuring out somebody had rheumatic heart disease and trying to manage someone like that on the ventilator. But really meaningful in the sense that we got to be with this family as they came, thinking that they would likely lose the husband would likely lose his wife to this illness, and then to see her just rapidly improve over the next few days as we took care of her, and our staff prayed with this family, hoping that somehow she would improve. So on the day of her discharge, this is our medical director and whenever we have a really good outcome in the ICU where someone that we really expected would pass away ends up getting better, we would often have kind of a going away party for them and a time to pray and thank God for saving their life. And so this is him praying for this family and for thanking God for saving her life. And I was so thankful because, if I was here in the US, the chance of taking care of someone like this, very unlikely. But because I was there in a place like India, where many people have so little access to care, that I was able to meld together my faith and practically apply that into taking care of really sick people, and to see them get better and being restored to their family. It was something so meaningful for me. And I think that's when I realized, that's what life is about. And that's what makes a job meaningful, is that if you find that what you're doing in a job is purposeful, then it makes that process of caring for someone so much more enjoyable and something that you can sustain you throughout your career. Kind of the next lesson that I've learned over the years is that all people ultimately grapple with the same fundamental questions. It doesn't really matter if you're rich or poor. When you face death and when you face the reality of an illness that potentially can debilitate you or potentially take your life, all people are ultimately the same. And I want to give you a couple examples. When I was at the Mayo Clinic, we took care of very, very wealthy patient people that would travel from around the world. Most of the Saudi princes would use the clinic as their primary place for them to get healthcare. Billionaires would come in. So very rich people. And then I want to show you a story of a boy that I took care of in Bihar, very poor. And then the fact that the questions that they ask is the same. I took care of a man that was the Speaker of the House of one of the Middle Eastern governments, and he'd come there to the Mayo Clinic to get treatment for his advanced pancreatic cancer. And I had built up a relationship with him. I actually had visited him in the home that he was staying at while he was getting care. And it's the same question that many patients have asked me, why did this happen to me? Is there a God that cares about my suffering? What will happen to me when I die? And the really question is, how do you respond when people ask these really hard metaphysical questions, right? About why did illness happen? What happens to me when I die? And I think you have to be prepared to answer them, and to answer them in a way that helps patients understand and grapple with their illness and make sense of what's going on in their life. So this was a boy that I took care of, Duncan. It's an 11-year-old boy who had found out that his father had cancer, and he was overwhelmed by the diagnosis of thinking that his father would pass away soon. And he didn't know what to do. And so that morning when he was going to school, he had found a bottle of poison and drank it down. And the school bus driver noticed that this boy was not acting right. And rather than take him to school, drove him to the hospital where I met him. And this is his initial exam. Press the record button. So you can see there's just froth coming out of his nose. And he's having a hard time breathing. His oxygen level at this point is about 80%. He's going in and out of consciousness. His heart rate is about 60. And just very wet. And just everywhere you can look at, there's fluid coming out. And when I listen to his lungs, the lungs are extremely wet. And once I intubate him, the clue to his diagnosis is pupils. The pupils are pinpoint. And whenever we see this, it almost always means an organophosphate has been ingested. It was the most common poisoning we saw at Duncan Hospital. About 300 to 400 cases a year of people that tried to commit suicide, primarily by taking a pesticide, mainly because it was easily available, because it's an agrarian society and people have access to pesticide. The treatment really is large amounts of atropine to be able to control the secretions, and then you give it until their lungs clear, and then you slowly take the atropine down over the next few days, which is what we did for this boy. And but then he developed a second complication. And of course, during this time, I'm talking to the mom and dad, and the same questions, right? The same question that the Speaker of the House asked me, why did this happen to my son? what happens if he dies? Why did God allow for this to happen? And not easy questions to answer, and not ones that have easy answers. So this is him 3 days later after he had taken this organophosphate. He's still on the ventilator. I've taken off all sedation. I'm asking him to sit up for me.
Yes. Yes.
You can see he's awake. He can move his eyes.
Always
That's
there.
it.
Yes. Yes, they cool.
And then try to help him sit up. And you can see he's lost all control of his muscles. He can't keep his head up. And whenever we see this with someone that has taken organophosphate, almost always means they developed a serious complication called intermediate syndrome. About 20% of our patients with organophosphates would have this. And it's a progressive weakness that occurs over the next 2 to 3 days, resulting in eventual respiratory paralysis. So we ended up having to put him on a ventilator. And they look like they're dead. I mean, they have complete lack of ability to move almost any muscle. Sometimes they have no reflexes at all. And you'll often give up thinking that the patient actually has fully died unless you get an EEG and you find out they still have brain activity. As long as you can get them through about 2 to 4 weeks of really good care where you help them with their breathing, many of them will recover. And this is that same boy with his father. About 2 weeks after he got out of the hospital, he had actually been in the hospital for about 4 weeks. And you can see the bandage over his neck from where we had done the tracheostomy. And he was getting ready to return back to school. And it was so good because as I took care of this boy, I mean, pretty much every day I prayed with this family that somehow God would allow for his son to live, and to see him being restored to his family was just such a blessing. And the family, after they got discharged, wanted to say a thank you to the hospital and the people that took care of them. And so I wanted to share a little bit of their own words of the care they got at the hospital. And so this is mom and dad talking about his care.
मैं दिल से कहती हूँ कि मतलब आज जो भी है मेरा बेटा ये हॉस्पिटल यहाँ डॉक्टर के नर्स लोग की वजह से और डॉक्टर कृष्ण की वजह से मैं तो ये हमेशा याद रखूंगी, इस जन्म में तो हमेशा याद रखूंगी कि मेरा बेटा का दूसरा रिवॉर्ड फॉर मी।
बहुत अच्छा।
और ये डंकन के पूरे स्टाफ लोग, पूरे मतलब जितने हैं लोग, सब कोई बहुत ज्यादा।
So for this family, you know, it was such an amazing experience to see these big questions about why did this happen? I don't know why it happened, but through that, we were able to see God work in this family's life, and to see our son being restored to him, and his relationship with dad changed in a way that that nobody would have ever imagined. And then he was able to return back to school and to get back to his class. And so it was just good to see how God had worked in this family's life. The next lesson is that sometimes you have to be more than a doctor to your patients. What do I mean by that? You know, sometimes you think that your job as a physician ends when you make the diagnosis or prescribe the right treatment. But I think that being a physician means being a lot more than that. You have to really invest in the lives of your patients. And I wanted to share a story of a young woman that I met, and just how our lives intertwined together. I've changed her name. We'll call her Nadine. This actually is a young woman that I met while I was working here in the US. She was 16 and had come into me to see, come to the emergency department because she was having abdominal pain. And as soon as I examined her abdomen, it was very clear that she had a protuberant uterus, and I could feel the top of her uterus kind of right below the umbilicus, which pretty much meant to me that she was likely pregnant. I did a bedside ultrasound, which confirmed the diagnosis that she probably was in the early part of her second trimester and she was pregnant. Of course, you tell her this, and she's absolutely devastated. This was, of course, an unplanned pregnancy. She came actually from a very conservative African nation, and was with her family who were immigrants. And she's just like, Dr. Philip, I don't know what to do. I have to get rid of this baby, because if my parents find out, they'll kill me, because there's no way they're going to allow me to have this child. And so I need you to figure out, or help me figure out how to get rid of this baby. And one of the things that I had talked with my wife and we discussed many years ago before I started my career in medicine was that one of the things we talked about is we very much believe in the sanctity of life and feeling that life is important from the time that God creates it. And we said, but it isn't important just to say that life is valuable. That you have to be willing to act on it, and sometimes that means going the extra mile for a patient. And what do I mean by that? So what I talked to my wife about was that what we had discussed was that if I ever met a young woman that was pregnant, it was an unexpected pregnancy. One of the things that I said with the permission of my wife that we would convey to them was that, look, if you want to carry this pregnancy to term and you need someone to take care of this baby for you, we would be willing and happy to do that for you. And if you want to keep the baby, we'll help you get connected with resources to be able to help you through this process, because it's not going to be easy. And I made that offer to several patients over the years, people that found out they were pregnant very unexpectedly. And I made the same offer to Nadine. I said, look, I know this is an unexpected pregnancy. I know that you're not expecting to be pregnant at this point, and I know it's going to be really hard for you. But here's my number. You call me if you need some help, or if you want to get rid of the baby and have someone else take care of it, or if you want to keep the baby, whatever it is, if we can help you, feel free to call. Didn't think much of it until about 2 days later, I get a call around 10:30 at night, and there's this little voice on the other side and says, Dr. Philip, do you remember me? I'm the girl you met a couple days ago at the hospital that you told me that to call you if I needed some help. And I need some help because my parents have kicked me out of the house because I told them I was pregnant and I don't know where to go and I don't have a place to go. Can you help me? And my wife, who's been always so supportive, said, hey, just give me her address. Where is she staying at? And I'll go pick her up. And so at 10:30 at night, I put the kids to bed and my wife went and met Nadine and picked her up. And she found out that actually she had an aunt who was willing to take her in, and went and dropped her off. And then over the next 6 months, my wife had an ongoing contact with Nadine, helping her through the pregnancy, getting her supplies. And one of the greatest joys for us was about 6-7 months later, she texted a picture of her son that was born and with her family that had come to terms with the fact that, yes, even though this was an unexpected pregnancy, this was something that they still wanted to keep the baby and she wanted to keep the child. And we were so glad that we had the opportunity to be involved in her life, even though it was more than being just a physician to her. Maybe this will answer kind of Taylor's question earlier about how sometimes not everything in medicine is explained by science. What do I mean by that? Over the years of practicing, I've seen so many things that I cannot explain just by my knowledge of science. I mean, there are things that I've seen in medicine that makes me think, there has to be a higher power, someone else that's intervening in the lives of men, because nothing in my teaching or my understanding of medicine would help explain why something would happen. And I wanted to share a story of someone where this really struck me. This boy, his name is Upender. Upender was 14 years old, and he came to us actually by his father because he'd been getting more and more confused over the past 5 days. And by the time he arrived, he was already in a coma. He was barely breathing. And I saw him in the emergency department, and I intubated him because he was just in respiratory failure. And this is his initial eye exam. And once you learn some more about neurology, you'll realize why this eye exam is such a terrible exam, because it tells you what's going on in his brain. This is Upender's right eye. The right eye is normal, but as you can see on his left eye is dilated and it's fixed. We see that people have a dilated, fixed pupil when their brain stem is herniating. As the midbrain herniates down, it hits the nerve that controls the pupillary reflex, cranial nerve number 3, and it dilates it out as the brain is pushing down through the brain stem. And usually this is the last thing we see before a person dies, is they have unequal pupils. And that usually means that they're on the imminent verge of death because their brainstem is herniating. I saw his exam and I knew this child was going to die. So I talked to his father and I said, look, Upender looks like he's going to die. I mean, there's no way that he's going to make it through because he's already herniating. I said, I don't know what to do. All we can do at this point is pray and that somehow God would be gracious to your son and would help him get better. But as far as what I can do, there's not much because I don't have a neurosurgeon that can open up his skull to relieve the pressure. So all I can do right now is pray and give some medicines and see what happens. And I fully expected that later that evening, I'd be getting a call from the ICU from one of my nurses saying this boy had died. But I didn't get a call. In fact, the next morning I went to go see him and he's on the ventilator and this is him awake. You can still see he has left-sided facial paralysis, but his dilated pupils are gone now. And he's starting to respond. And when the father asked what had happened, I said, well, I don't know. All I can say is that God heard our prayers and your son is better because nothing that I have done would make a child get better this quickly, especially with his initial exam. 24 hours later, he came off the ventilator. This is his exam. I'm asking what his name is.
Huh?
And he's talking now. And when we finally got him stable enough, I did a lumbar puncture and you can see there's pus coming out of his CSF. And he has 14,000 white cells in there. Its protein is very high, almost 400. The sugar is 3, which is consistent with severe bacterial meningitis, which is what was causing the pressure in his brain and causing him to herniate. And the father realized that something miraculous had happened with his son. And so before his son left the hospital, we actually put him on IV antibiotics for the next, I think, 7 or 14 days. He said, before I leave here, I want to come up to the chapel and I want to thank God for saving my son. And so this is Upender's father here. And he wanted to come to chapel to tell God, thank you for saving his son. Again, things that medically doesn't make any sense, but things that happened that I can explain nothing other than the hand of God working in this boy's life. 2 final lessons. A patient's faith plays a huge role in their healing. I firmly believe that faith has a huge role in terms of how we care for patients, but it also makes a huge difference in terms of how patients get better. This is a boy that I took care of. It's a 6-year-old boy that came in respiratory distress with fever for 3 weeks. He's unable to lie down. The story of this boy is that he had actually been sick for quite a bit of time. Even before the fever had begun, he'd been losing weight. And then the father had heard that there was a mission hospital someplace far away that could take care of him. Potentially it would be worthwhile taking his son to. So he got on a bus and then an overnight train. So he traveled 15 hours and then carried his son probably the last 2 hours from the railway station to us and brought him to the hospital where I met him. And he had heard that there was somebody that maybe might be able to help take care of his son and help him get better. But when he came, very, very sick. So here's the child's initial x-ray. So you can see his cardiomegaly, the heart is quite large. He's got an infiltrate. Whenever we see an infiltrate, especially in the right upper lobe in India, we always think TB. And he was unable to lie flat. He was having a hard time breathing. And so I did an echocardiogram, and this is his echo. So there's the heart beating. And as you can see, there's all this fluid around the heart, and he's got a pericardial effusion. So we need to make a diagnosis, and the only way we can do that is by doing what's called a pericardiocentesis, where we take a needle and stick it into the sac around the heart and get some fluid off so we can make a diagnosis. So this is us doing that. So there's his heart beating there. And I've given the baby some sedation.
That's when I tried to hit with my knee.
And I'm going to take a needle. It's actually a spinal needle. It's pretty long that I can then guide under ultrasound to the sac around the heart so that I can get some fluid out to figure out what the diagnosis is. So you can see my needles coming in right there. And then you can see the serous colored fluid coming out. We sent that for analysis and it confirmed the diagnosis of TB pericarditis. And so as I often do with my patients, I asked this father, I said, would you mind if I took a moment and I prayed for you and for your son that he would get better and the treatment we give him would help him to improve? And this man's faith was great. He said, doctor, I came all the way here because I had heard that there were people here that cared. Would you mind if I if I prayed for my son? I said, go right ahead. So he did. And his faith was rewarded. This is him a week later. This is the first night this boy had been able to sleep now in almost 4 weeks, and getting better because the diagnosis was a TB infection around his heart. And on the right treatment and steroids, he was starting to improve. And this father was able to see his faith come to fruition, and the fact that the faith to bring his son 15 hours away to take care of him and then to see his son improve was really an amazing thing. I want to end this talk with one other lesson, and that lesson is that living out your convictions is often costly. What do I mean by that? My career in medicine was primarily motivated by my desire to be able to use my faith practically and to live it out. And so, I'd gone to India, and my entire medical training was so that I could go work at a mission hospital long-term. That's really was our plan, is that we would be there until our career was done, was caring for patients in these remote parts of India. And I really thought that's what I would get to do. But that doesn't always work the way that we would think. So in 2016, I had gone to teach at a conference with my family in Greece, and we visited some friends in Spain, after which we had flown to India. And when I got to the airport in Delhi, my wife and kids got through immigration without any difficulty. But as soon as my passport was scanned, all of a sudden I see this red flashing screen come up, and soon the officer that's there gets very concerned, and soon I'm surrounded by maybe 6 or 7 other immigration officials asking me what I'm doing, why are you here? And I said, well, I work at a hospital in northern India called Duncan Hospital, and I'm the physician there. I take care of patients in the emergency department. And they informed me then that as of that day, I was no longer allowed to be back in India, even though that's the country that I was born, and that I was going to be given an hour to leave the country because I was no longer welcome there. I asked them, well, what I had done that was wrong. They didn't give me any answers. They just said that there's been an order from the government, and the government has ordered that you are no longer welcome in the country. You're on a blacklist, and so you have an hour to leave. And that was probably the most painful day of my life. I had soon I was surrounded by a couple more police officers, and then taken to a detention area in the airport in Delhi. And I was separated from my wife and my children, who were behind a glass area. And I could see my kids crying and wondering, why is dad in trouble? What has he done deserving of this? And no answers. And I said goodbye to my family. They took me, and they actually kept the plane waiting that had landed until I was able to get back on the airplane. And they deported me from the country, and they said, you are not allowed to come back to the country ever again. And so I remember getting on that plane and looking out the window and wondering if I would ever see my home again, and wondering why, I had been faithful to what God asked me to do, which was to give my life to service and to serve those that others had forgotten. And I didn't understand why this had happened and why I was being sent away from this country that I loved so much and the people that I loved. I was then taken from there to Turkey, where I was then put in another detention cell for the next 24 hours in Istanbul, waiting for further deportation to Spain, where I started our journey. So 24 hours later, I was handed over to the Spanish authorities, who couldn't figure out why exactly I was back there. And I explained the same thing. I said, I don't understand why I'm back here either. And my wife then had the difficult job of taking our 3 children, going back to our home and collecting whatever they could and leaving the country to join me again. I then spent another 2 weeks apart from them, and then flew to Nepal, where I met my family, and then we returned back to the US. Many questions then about why it happened, what I had done wrong, We approached the Indian government to find some answers, and we actually filed a case within the High Court in Delhi, seeking to figure out what exactly I was accused of. The government would tell me nothing more than that I was considered a high threat to the government, and because of that, even the charges against me would not be disclosed. So here I was fighting my deportation without even knowing what I was charged with or accused of doing wrong. And it was a very painful time. And I questioned many times why God allowed for that to happen, because I had followed through on what God had asked me to do, which was to be able to go and work in this really remote part of the world. I had never had a single complaint from anyone in the community or the patients I cared for that I'd done anything to them that was threatening. And then to be accused of things that I wasn't even sure what I was accused of was very disheartening. So we fought the case in the Indian courts for many years. In fact, 3 years we spent in court. And of course, I was never allowed to even defend myself because I was not allowed back in the country. So the lawyers spoke on my behalf. And after many years, it finally came out that it was because I was working at a mission hospital, and because of my Christian background, they did not feel that was wise to be able to have someone like me working in that part of India. So we challenged the reason why they had deported me, and lots of things were written over the years about the harassment and the struggles we faced. So a couple of articles about that. And finally, in January of 2019, we had a major victory where the High Court recognized that what we were doing was honorable, that we had not done anything in a way that was trying to hide something as to why we were there. I said, look, I'm a Christian, and that's who I am. And yes, I serve people, and I take care of patients, and I care for them because that's how Christ asked us to care for people. And for that to be a crime is preposterous. And finally, the High Court agreed with us that what the government did was illegal, that there was no basis for which they had sent me out of the country, and they ordered that my rights to be able to return back to India would be restored. And I was so happy that last March, me and our oldest 3 kids were able to enter back into India. What this whole thing kind of showed for me is that following your convictions is costly. I mean, I had worked for 17 years getting ready to go to India and serving there. And then in an instant, all of that was gone. I lost everything, my family, the work that I was involved with. 3 years of my life I lost after that, waiting for a decision in this case. And I think that's what you'll realize is that just because you follow your convictions doesn't mean that things go easy for you. In fact, many times you get persecuted for that. I wanted to share one more thing. So when we came back to the US, one of the things as far as following our convictions was we felt that it was really important that if we cared about children, that we would act on that. And so we had decided to adopt initially 5 kids, and then over the last 2 years, their 2 siblings joined us. So that's our first one, number 9, and number 10. And that's also is a costly decision, right? Yes, we felt convicted that kids that were in a neglected or abused background needed to have homes, but this is not an easy thing to do either. One of our kids that we adopted was on multiple psychiatric medications before she came to us, and the first probably 6 months to a year were so difficult. Number of times I'd walk in, I'd come back, finish up my shift, and I'd see my wife black and blue from the time where one of them had hit her, and because they were angry, they were upset. And I think that's what I mean by that, is that when you follow your convictions, it's not easy. God sometimes calls us to do very hard things. To go to India was a hard thing. To adopt 7 kids is a hard thing, right? And he doesn't say that just because you follow through on that things will be easy. In fact, it can be very costly, and it can consume not only your time, your resources, your money. It can it can cost you a lot to follow through on your convictions. So with that, I'll finish, and I'll turn it back over to Taylor and Dr. Flower if you have any other questions.
I think what everyone is also just wanting you to know is that we think that your story is literally so inspiring and amazing, and that you've moved us all throughout this entire presentation, and you just blow me away. And I think everyone else feels the same way. There's not a lot of people out there in the world like you. So let's go to some of the questions. Okay, so do you find that you have a specific special bond with doctors and or patients who are religious in your field, not only Christians, but other religions as well?
Yeah, I think, there's some of the patients that I've been most blessed by. One of the things that I frequently offer my patients, and especially when I'm delivering news that's unexpected. One of the worst jobs that we have as an ER physician is we're often the person that somebody meets on their worst day. I'm the one that has to tell a mother that their son has died in a car accident. I'm the one that has to tell, a young mother that they've got cancer that's metastatic. And one of the things that I have often offered in those situations, I just tell them, look, I'm a person of faith, and medicines are good, but ultimately it's God that provides healing. And I know you're going through a really difficult time. Would you mind if I took a moment and prayed for you? And what's been really neat has been over the years, how many of my patients have responded back to that? I've had, there are maybe 2 or 3 patients in 12 years of offering that have said, no, I'm not interested. That's fine. That's your choice. But the vast majority are so thankful that I thought about them and the fact that there's a spiritual aspect of their suffering. And sometimes the biggest blessings that I've had has been when patients have offered to pray for me. I think of one particular one. I had probably a 40-year-old Hispanic woman that I took care of that had metastatic cancer. She was dying, and she knew it. And this was going to be, I think I met her in November. She said, I don't think I'll make it through December. But she was a woman of very solid faith and very concerned about, and she knew where she was going to go when she died. And I offered to pray with her, and she allowed me to do that. But after that, I said, Dr. Philip, do you mind if I took a moment and I prayed for you? And I said, sure, I love it. And then to hear this woman pray for me and for caring for my patients, the people that I meet during that day, it was so encouraging. Here's a woman that knew she was going to die. She had maybe a month or 2 left to live, but that she had the graciousness in her heart to care about me as a physician and realize that, the things that we see each day are not easy. And they're very emotionally taxing. And the fact that she took the time to pray for me was such a refreshment. And I can't think of the number of times when I felt very worn down that God has brought a patient like that to me. In fact, probably last week, I had an elderly man and woman that I was taking care of, and I'd offered the same thing. I prayed with them, and then he asked me, hey, is there something I can be praying for you about? And I said, yeah, my daughter, we're waiting to finalize her adoption, but it's stuck in an appellate court, and I don't know when it's going to happen. She said, brother, I want to pray for you right now. And that was such an encouragement to me to be able to see them and to respond in kind. So I think those have been some of the best moments that I've had as a physician, is being able to share that.
That's so great. Okay. Someone asked, how are you able to communicate with so many language barriers when you were working outside of the country?
Yeah, so language barriers are a huge, difficult thing. I actually learned Hindi and actually spent the first 6 months when I was in India learning Hindi, which made it easier. Still was not completely proficient in it. The problem we had in our particular area was that the trade language is Hindi, but the local language is a language called Bhojpuri. And then there's a second language spoken there, which is Nepali. And I definitely didn't know Bhojpuri and Nepali. So many times it was like translator to translator to translator. So I would go in English, somebody would translate into Hindi, and somebody would translate from Hindi then to Bhojpuri, and then the patient would talk to them. We kind of go back and forth. So I think if you can learn a language, especially a patient's heart language, it's definitely so much easier to communicate with them. I feel like that goes a long way to gaining a person's trust. But in a particular area like where we were at, where there were so many languages, we just had to rely on translator. And I found people that would translate well, that had that had, because there are people that translate well and there are people that translate poorly. And I think the difference is in the way that, how empathic they are, right? People that are able to convey what you're trying to describe, the same empathy you're trying to communicate in your home language, I think that makes it a lot easier. So I think I found a couple of nurses that could do that really well for me, and I'd always call on them to be able to come and help me, especially if it was where we had to do 2 or 3 different jumps in order to get to the right language for the patient.
Alrighty, okay, and then is there any way to be able to get these underserved areas vaccines to help lessen these preventable illnesses?
Yeah, in fact, vaccines are actually available especially, I'll tell you, in India, they're available at the government health center. The issue not is the lack of availability, the issue is the lack of accountability in terms of distributing them. What we found is that many of the government centers that were approved to do vaccinations, maybe they would have vaccines, but they didn't have a refrigerator that could keep them cool. So get a lot of vaccines, but within a day, they would all be lost because they didn't have a refrigerator to put them in, or the refrigerator wasn't working properly. So it was really sad for us to see so many good things that were being passed out by the government to these local centers, but because somebody wasn't checking to see, hey, do they have a refrigerator, right? A lot of vaccines would get lost. The other thing I think we found was that a lot of it was really mistrust. And I think what we found is that the better we could, in terms of helping to build trust in the community, the more likely they were able to listen and follow through on trying to, hey, look, it's important to get these vaccines because they'll help your kids not to get sick in the future. But until you had learned or gained that trust, it was really hard to get them to follow through.
Gotcha. And then another good question that we had was, what were the processes that you went through to get a degree in a country and then practice in another?
Yeah, so that was a long process too, and lots of visits to government officials. I had my US board certification in emergency medicine, and then there's an Indian Medical Council that I then had to submit my forms to, saying that, look, I had already gotten licensed in the US. And because I was in a special category called an overseas citizen of India, it's someone that almost has a dual citizenship. Normally you'd have to take the Indian licensing exam in order to be able to get to practice in India. But because I was in the special category, as long as I submitted my paperwork, they would look and make sure that they were recognized by the US board, and they would recognize the Indian board. Now, of course, working in a very corrupt system, it's not very easy because everyone expected that a bribe would go along with the documents that I submitted, and I wasn't willing to pay a bribe. So that took many visits to the government officials to say, look, hey, I submitted my paperwork, everything is in order. Why have you not issued my license yet? And I think I made 4 or 5 24-hour journeys from where we were at to visit the office to get them to finally submit my final license. So it's lots of persistence, which I think is what you'll find in any developing country is eventually you knock enough and they get tired of you and they'll finally let you have what you're looking for, but it requires a lot of persistence.
Okay. Do you keep in touch with your patients if they have the resources to keep in touch with you?
Yes, I have, especially in India. Many of my patients, because you built up a relationship with them, many of them have invited me to their homes. And so that was a great way to get to know them. It was always interesting because whenever I'd go to the market, it's a fairly large city, maybe 50 or 100,000 people. But it was always heartening for me whenever I'd go to the market. Multiple people would recognize I had taken care of them or their family member. And they'd be like, oh, it's Dr. Christo, please come in, have tea with me, have tea with my family. And so that was always exciting. And that allowed for ongoing contact with the patient. It's a little bit harder here in the US, just because of HIPAA rules, things like that. But there have been actually one of my favorite stories from here. When I came back, 2017, I had a 13-year-old boy that had arrested while playing basketball. I took care of him. He was in cardiac arrest for almost 20 minutes before he finally got him back. Ended up being that he had a very complicated course. He ended up having a anomaly in his coronary artery vessel. And it was really neat because a year from the day that he had died for like 20 minutes, his family came back up to the emergency department to thank the people that had taken care of him. And that night I was working and I saw him and I was so happy to see him. And they were so excited to see the doctor that took care of their son was the one that was there that night. And we've had an ongoing relationship since then, just because I've gotten to know them. So I think there's been opportunities like that.
That's really cool that you've been able to like keep in touch with everyone, because I feel like it's something that not everyone gets to do, and so it must feel different.
Yeah.
I guess we have a couple questions left, and I think you kind of hit on this, but so what do you tell your patients when maybe some parent might ask, like, why did God do this to my child, or why is my child going through this?
Yeah. Really hard. And sometimes I tell them, look, I don't have an answer. But what I can tell you is that God does care about what you're going through and the suffering that you're going through. And he'll walk with you through this. And part of the reason why things happen that we don't expect is that we live in a fallen world and there are things that go wrong. And I don't have any clear, easy answers to why it happens. But what I can promise you is that God is not unaware of your suffering. And he says that if you're willing to call out to him, he's willing to listen and meet you where you are. And I found that that's been a comforting answer to the vast majority of my patients. I mean, it's not an easy answer. I don't know why it happens. Why does one particular child get an illness? I don't know. But I do know that, God does say that he'll give us strength as he goes through these difficult trials. And that's what I can give them hope for, is that, look, you're not alone in this. God will walk with you through this.
Thank you for sharing. Okay, Dr. Fowler, do you have any last questions you might want to throw out there? Anybody? Yeah.
Christo, I don't have words. The first time I heard part of this talk, when you presented it at a conference a couple of years ago, I was just sitting in the back, and now you have emptied my tissue box, Christo. So you've done it again. I don't have words, Christo. What an astonishing individual, man of faith, husband, father, great doctor, incredible intellectual, loving person. You talked to 1,000 kids tonight, and let's have everybody say thank you, Dr. Matt, so he can see that, please. Here they come. Here comes the flood of thank yous, Christo. Christo Phillips, you're an amazing person. You've touched many lives tonight. This 1,000 people online tonight will go see 100,000 patients themselves. And so tonight you've touched 100 million lives in the future because of your amazing persistence, your study, and your commitment and your faith. We love you, buddy. Thank you so much.
Great, Matt. Something really quick, if I might.
Please, Gil.
Christo, I had the privilege to train you when you were a resident. We're not that much apart in age, but the opportunity to witness how great of a doctor you've been for a number of years, it's just astounding to me. I strive to be like you every day, and I hope that every single pre-medical student learning tonight kind of sees what a long journey you've gone through, what a wonderful person you are, and what a difference you can make in the world with a little bit of kindness. So keep up the good work, my friend. We love you.
Thanks, yeah.
Crystal, let's have the next slide, please. I believe that's the one that has the exam on it. Here we are. So everyone, please take notice. The pin number is 2. Go ahead, Taylor.
Oh no, you can go. Take it away.
Well, so the Quest Base exam is now ready. The pin number 2342-6028-2340. You have to have the hyphens, and the password is Philip. It's a capital P. The completion date on the exam is October the 6th at 6:59 p.m. right before the session. And so on behalf of all of the team at Virtual Shadowing, on behalf of Dr. Phillip and Dr. Salazar, who presented the wonderful talk last week, we want to thank you for joining us and the 24,400 people who have signed up at the Virtual Shadowing website. We will continue to be here as long as you keep tuning in. So thank you, everyone. Thank you for coming. It's an honor to be part of your lives and your careers. And on behalf of the whole Virtual Shadowing team, we would wish you